So our next speaker is Anu Gopalan, who's also a member of the GU pathology team and an associate pathologist. Anu began her work on prostate cancer with William Gerald and has done a lot of work on the genomics, in particular looking at the clinical significance of the TMPRSS-ERG fusion versus amplification, and more recently looking at global genomic analysis of prostate cancer. So Anu, we look forward to your talk.
Thank you, David, for the introduction, and I'd like to welcome everyone to this year's alumni meeting and also congratulate Dr. Epstein on the Stewart Award. So there's been multiple recent advances in the molecular genomics in prostate cancer. In the last few years, we've had the TCGA with elaboration of the molecular advances in molecular findings in primary prostate cancers, over 300 primary prostate cancers. The Stand Up to Cancer initiative focused on 150 metastatic prostate cancers. Again, an integrative multi-institutional analysis. There have been several discoveries in neuroendocrine prostate cancer as well, including the co-occurrence of P53 and RB mutations, the relative lack of AR molecular abnormalities as opposed to adenocarcinomas in the prostate. And there have been advances in the DNA damage repair pathway as well, which is what I'm going to focus on in today's talk. In these, I'm going to first focus on the MMR deficient prostate cancers, as well as briefly touch upon more preliminary work in homologous recombination repair gene pathway mutations and the pathologic and clinical aspects of those abnormalities. So just overview of the DNA mismatch repair pathway and microsatellite instability. There are 4 major mismatch repair proteins: MSH2, MSH6, MLH1, and PMS2, as you're all very well aware. Lynch syndrome is an autosomal dominant single allele germline mutation in an MMR gene with the second allelic hit happening in somatic cells within a tumor, either because of a mutation or loss of heterozygosity or methylation of the gene. Sporadic MMR deficiency can happen as well, and that happens because of somatic biallelic inactivation or methylation of MMR genes. And the molecular phenotype of both hereditary Lynch as well as sporadic tumors is microsatellite instability, or MSI. These are the screening tools that have been used for detection of MSI in tumors. This follows a paradigm of colorectal cancers where it's best characterized. Family history is important. The pathologic characteristics of the tumor are important. Colon cancers with MSI happen more often in the right side of the colon. They have characteristic pathogenic histologic abnormalities, histologic features. They're solid, more poorly differentiated, typically have an increase in tumor-infiltrating lymphocytes, which are cytotoxic and activated T lymphocytes. Immunohistochemistry for MMR proteins is the next screening tool: MLH1, PMS2, MSH2, and MSH6, as well as tumor DNA microsatellite instability detection by PCR, as well as recently by next-generation sequencing efforts. So the implications of microsatellite instability in colorectal cancers, the most important would be germline screening of family members to detect other family members with cancers. Prognosis, generally microsatellite unstable colon cancers do better than their the microsatellite stable counterparts, as well as therapeutic implications. These tumors, which are MSI, typically do not respond as well to 5-fluorouracil and respond better to irinotecan, etc. So in case of prostate cancer, not much is known about microsatellite instability. Durable objective responses to immune checkpoint blockade has been seen, but till now they've shown just a limited benefit in prostate cancer. The spotlight has been shining on this because of the recent accelerated FDA approval for antibodies to the programmed cell death receptor, PD-1 and L1 inhibitors for the treatment of all solid tumors with mismatch repair deficiency, particularly advanced tumors, independent of the site of origin. And therefore, my MSI detection represents the first clinical indication for prospective tumors profiling in prostate cancer patients. However, the optimal method for determination of MSI or mismatch repair deficient status in prostate cancer is still uncertain. So what is known about MSI in the Prostate Cancer Journal? The first study in the top is a large study which looks at over 5,000 men with where 97 of them had a cumulative Lynch syndrome, and they had a cumulative lifetime risk of prostate cancer in these patients, which is twofold higher than that in the general population. The rate was slightly higher in carriers who were diagnosed before 60 years. The study at the bottom is a multi-institutional large study again, which MSK participated in, and it looked into multiple sequencing assays to detect germline mutations in 20 DNA repair genes in over 700 metastatic prostate cancers. And as you can see here, the incidence of germline mutations in metastatic prostate cancers was about 12%, which is far higher than that in primary or localized prostate cancers. Included in these cases were 2 samples with PMS2 mutations and 1 sample each with MSH2 and MSH6 mutations. So as you can see, MSI, prostate cancer, forms a very, very small percentage of the overall DNA repair mutations in prostate cancer. So what do we know about sporadic microsatellite instability in prostate cancer? This is one of the largest studies from the University of Washington group, which looked at 60 advanced prostate cancers and found that 12% of these cases, 7 in their cohort of 60, were hypermutated. All of the hypermutated tumors in their study showed MMR gene mutations and microsatellite instability. And they found that the majority, 4 of 7, involved MSH2 and MSH6. This study did not report on the molecular features of these mismatch repair sporadic MSI tumors. This is a study from the Johns Hopkins group led by Tamara Lotan, who is one of Dr. Epstein's fellows, former fellows, which looked at basically at MSH2 immunohistochemical loss in primary prostate cancer. And they looked at several different TMAs, counting for about more than 1,100 cases. And they found a very, very low percentage, 1.2%. So 14 out of the roughly 1,100 cases showed MSH2 IHC loss in both primary adenocarcinoma as well as a couple of TMAs with neuroendocrine prostate cancers. They also found that about 8% of adenocarcinomas with Gleason score 9 to 10 versus 9 and 10, meaning most of these cancers with MSI were in higher tumors of higher Gleason grade as compared to other Gleason scores. There was homogeneous loss by IHC, so they thought this was a clonal event. They also had some correlation with MSI by PCR and by MSyncs, by next generation sequencing. They found a 61 and a 58% correlation with PCR and NGS respectively. And this was correlated with a higher density of CD8 positive tumor infiltrating lymphocytes. The next few slides I will highlight our study on the study of these tumors. So we sequenced 1,500 tumor samples from 1,346 patients with MSK IMPACT. And the MSI census score, which is basically a software algorithm, which looks at microsatellite sites and derives a quantitative score of microsatellite instability, was used to stratify these tumors as MSI high, where the MSI census score was greater than 10, 10 or greater than 10, MSI intermediate or indeterminate when the census score was 3 to 9, and MSI low when the census score was less than 3. We had tumor mutation burden available in these cases, and this was represented as mutations per megabase. Mutational signature analysis was also done in selected cases where the somatic mutation counts were in excess of 10. Data on MMR gene alterations were available, including deleterious alterations, including germline, inactivating somatic truncating mutations, as well as deletions. We performed IHC for MMR proteins, all 4 MMR proteins in select cases, and correlated them with sequencing results. Looked into the morphology of these tumors and had some data on clinical outcomes of these tumors. So this study was recently accepted into JAMA Oncology, and I'm presenting a lot of the figures and data from that study. Here's the clinical and pathologic features of the mismatch repair deficient, or the MSI high cohort, which numbered a total of 32. Most of the cases were Gleason 8 to 10, over 50% of were Gleason 8 to 10, and over 75% were showed Gleason 7 to 10. The majority were metastatic tumors, over 90%, actually over 80%, of which the vast majority were castration-resistant prostate, metastatic prostate cancer. Bone and lymph nodes were the most common sites of metastasis, but other sites, including visceral sites, including lung, liver, and soft tissue sites, are also represented. This is a plot which shows the mutational burden against the MSI census scores. So when you have, if you look at the leftmost panel, which is the MSI census, cases with MSI census scores of less than 3%, the majority had a tumor mutation burden below 10, with the exception of one case, which is a prominently hypermutated case, which had a POL-E mutation. Most of the cases, or all of the cases with MSI census scores over 10 were hypermutated. In the indeterminate category, where you see the red dots, where most of the red dots are located, those are the cases where, based on exceptional mutational burden or immunohistochemical evidence of mismatch repair deficiency, they were classified as MSI high. So this is a slide that shows the integrative analysis of tumors with high tumor mutation burden over 10 and indeterminate and high MSI census scores. And the tumors that are represented on the left side, the figures on the left, are all the tumors with the red dots on this figure, which I've carried over from the previous slide. The top bar is the mutations per megabase. So you can see the red line, which demonstrates that all of these tumors had a tumor mutation burden of over 10 per megabase. The second column, the second row, is the MSI census scores. And I'd like to particularly highlight the cases with MSI census scores between 3 and 10, the indeterminate category, where we call it MSI high only if there was a deleterious alteration in an mismatch repair gene, or if there was immunohistochemical evidence for mismatch repair protein loss. And this is the oncoprint showing the relevant mismatch repair gene alterations, as well as the IHC findings. We had 6 cases in this study which had more than one tumor analyzed. In the top, you can see the time at which the biopsy, the metastatic or the second or the paired biopsies were procured in relative to the primary biopsy, which is 0 months. So of these 6 cases, the first case represents a PMS2 germline mutation, where both the paired tumors showed PMS2 loss, a germline loss. The gray bars represent the primary or localized prostate cancers. The yellow bars represent the castration-resistant metastatic disease, and the green bar represents metastatic non-castrate prostate cancer. Samples 2 and 5 were samples where there was a somatic evidence of a somatic mutation in the second pair sample, as you can see here. Sample 5 does not have the primary sample represented because this was a radical prostatectomy, which had a very, very low MSI sensor count. I believe it was 2.5. And it did not have an evidence of a mismatch repair gene mutation. it did show evidence, we reflexed it to IHC, and it did show evidence of MSH6 loss. So these were the total sample numbers that were included in the study. The total number of patients who had sequencing results were 1346, and of which there was adequate tumor quality for MSI sensor assessment in 1033 tumors. I'd like to highlight 25% of these tumors, which amounted about 384, were excluded from the MSI sensor analysis because of low tumor purity, thereby had unreliable MSI sensor results. So the final tally we had were 167 tumors from 1,033 patients. Of these 1033 patients, 23 had a high MSI sensor score of greater than 10%, which formed about 2.2% of the total. In 28 cases, the MSI sensor score was indeterminate, and of which 9 had conclusive either MMR gene loss on MMR protein loss in immunohistochemistry or deleterious alteration in one of the MMR genes, which led to a total of 32 cases, or 3.1% of the entire cohort, which had a mismatch repair deficiency or an MSI high phenotype. 7 of these 32 patients had a germline mutation, so they were classified as Lynch syndrome. In the next couple of slides, I will focus on the immunohistochemical findings in these two MSI sensor categories, the high as well as the indeterminate. So this is these are the 23 MSI high patients based on MSI sensor, of which we had immunohistochemical data available in 14 of the cases. The majority of them, 13, had evidence of MSH2 and MSH6 protein loss. One had PMS2 and MLH1, which is, and all of these had the other two mismatch repair proteins retained. So it was a total of 13 cases with 93%. In the one case which did not show, which was not in this category, there was a germline loss of PMS2, and therefore PMS2 was lost. So we found an immunohistochemical concordance with MSI status of greater than 93% in cases with a hypermutated profile. This illustrates the case with the germline PMS2 mutation. We had 2 metachronous metastatic samples from the pelvic and pubic bones, which were taken 9 years apart. Both of these samples showed hypermutation. One had 23 mutations, and the other one had 6 mutations. And there was a germline missense mutation in this case, a PMS2 germline mutation. The MSI sensor score was high in the first one, but indeterminate in the second sample. I just wanted to illustrate that the first sample showed a weak and focal PMS2 retained expression, which was actually not, the second sample had a loss of PMS2 expression. So this is one of the limitations of immunohistochemistry, where you can sometimes find an edge artifact, which leads to a false positive immunohistochemical finding. And this has to be kept in mind while interpreting these stains. And this phenomenon has also been reported in colorectal cancers. In the MSI indeterminate, sensor indeterminate category, which was 28 patients, the majority of them were hypermutated, where 3 were, did not show, the majority of them were non-hypermutated. 3 of them with the hypermutated profile had immunohistochemistry available in 2 of the cases, where we did find a loss of MSH2 and MSH6 proteins. In the non-hypermutated category, we had immunohistochemistry available on 8 of them, and 4 were MMR proficient and 4 were MMR deficient. So the takeaway from this slide would be that IHC is most useful in the MSI indeterminate, non-hypermutated setting, and this should trigger a look into the germline as well as other investigations. In the study that was submitted, there were 11 of the 32 MSI high or mismatch repair deficient patients who received anti-PD-1 and anti-PD-L1 therapy, of which 6 or more than 50% had a PSA decline of greater than 50%, the top 5. 4 of 8 patients had a radiographic response, which are shown here. I've highlighted for you one of the most dramatic examples where there's a significant shrinkage of the tumor post-therapy. as highlighted by the red arrows. So based on our findings, we drew up some proposed guidelines for evaluation of the MSI high phenotype or mismatch repair deficiency. If there's adequate tumor purity for MSI sensor assessment, and you have reliable MSI sensor results based on stratification of MSI sensor scores, if you have an MSI sensor score of greater than 10, 10 or greater than 10, the tumors are unequivocally mismatch repair deficient or MSI high. If the MSI sensor score is indeterminate between 3 and 10, scores of 3 and 10, the next step would be to document either a deleterious MMR gene alteration or mismatch repair deficiency on IHC. If there's either one of the two assays are positive, then it would be an MSI high tumor. If none of these are positive, then it would be an MSI microsatellite stable or a mismatch repair proficient tumor. If there's not an adequate tumor purity for MSI sensor assessment, or if there's very limited tumor content which does not allow for sequencing, then the next step would be to consider IHC reflexly in those tumors. So just to summarize, when is IHC recommended in evaluation of these tumors? When there's an indeterminate MSI sensor score of 3 to 9, if there's inadequate tumor purity, which may lead to an unreliable MSI sensor score, or if there's low tumor content, which is insufficient for next generation sequencing. So I just wanted to show a slide with the status of those tumors which had isolated mismatch repair gene alterations, but not pathogenic alterations. We had 13 of those cases represented in this set. None of these were MSI high by MSI sensor. We had immunohistochemical data on 6 of these cases, and all of these were MMR proficient. So our thought is that these are unlikely to be driver mutations and more likely to be passenger mutations. We did find a very good immunohistochemical concordance in immunohistochemistry between matched samples. We had 3 primary met pairs with IHC data available, as well as in cases with more than 1 metastatic samples, except in the one case with the PMS2 germline mutation, where I illustrated that there was a false positive or false retained PMS2 that I showed in an earlier slide. We had a couple of cases that were pre and post treatment, both radiation and androgen deprivation therapy, and the immunohistochemistry was homogeneous. Results were homogeneous across those 2 paired samples. I just wanted to touch upon intratumoral heterogeneity in evaluation of MMR IHC in these slides. We had 2 cases of where we had the primary radical prostatectomies where we observed this phenomenon, and this is one of those 2 cases where the radical prostatectomy showed a tumor with Gleason score of Gleason grade of 8 and PT3B tumor stage. The top panel shows the MSH2 staining pattern, and the bottom panel shows the MSH6 staining pattern. And as you can see here, there was a clone of tumor that had loss of MSH2 and one just side by side with a retention of MSH2. And here there was a separate intraductal as well as a ductal component which had an MSH2 loss. And the same findings are replicated in MSH6 as well. There's been reports in colorectal cancers of this phenomenon where they've tried to compartmentalize it into intraglandular heterogeneity in evaluation of these proteins, as well as zonal or compartmental heterogeneity. So this intraglandular heterogeneity, meaning such as in this example where you have several nuclei within a particular gland, which are positive and some which have lost the protein, versus zonal heterogeneity where you have some glands side by side with glands that have retained the protein, as well as compartmental heterogeneity where entire foci of tumor across blocks have lost the protein versus retained the protein. So we observed this phenomenon in this one case in the prostatectomy as well. In the corresponding lymph node met, there was increased tumor mutational burden with 33 somatic mutations, There was no identifiable germline mutation in this tumor. The MSI sensor score was stable, but because of low tumor content, we presumed that the MSI sensors, the data were unreliable. And the explanations for this phenomenon is one of the two. It could either be because of variable isotope expression or second hit mutations or methylation in select tumor clones, which cause sort of a discrepancy in different clones in the same tumor. In terms of morphology of the MSI high tumors, we had 21 of the MSI high cases of the 23 had morphologic features associated with conventional prostatic adenocarcinoma, including acinar, cribriform, and ductal features. 2 cases had other morphologies. All primary tumors that we saw were Gleason 8 and higher, and as I mentioned, heterogeneity within the tumors observed in 2 cases. So this is the only tumor in our cohort that showed increased tumor infiltrating lymphocytes. This is a tumor that shows an essentially solid or poorly differentiated pattern where you can clearly appreciate an increased count of tumor infiltrating lymphocytes. This was a metastatic tumor in a pelvic lymph node. It was hypermutated, had 29 mutations. There were 2 mutations both in the MSH2 and as well as in the MSH6 genes. The MSI sensor score was high. On immunohistochemistry, both MSH2 and MSH6 were lost, as shown in the top panel, and the other 2 markers were retained. This is one of our cases where both the primary as well as the MET was a small cell carcinoma. The metastatic tumor was in the soft tissue. Both the tumors had a hypermutated profile with 26 and 36 mutations respectively. Mismatched repair gene alterations, pathogenic alterations were not found. The MSI sensor score was high in both primary as well as MET. And in the immunohistochemistry, we found that there was a loss of PMS2 and MSH6, which correlated with an MSI high status. But I just wanted to illustrate that in this case, we found PMS2 retained while the MLH1 was lost. This phenomenon is a limitation of immunohistochemistry, and it's very unusual to find that the PMS2 protein would be retained in the absence of an MLH1 mutation, because MLH1 and PMS2 are obligate partners, and to have a functional to have a retained PMS2 protein, one would have to have a functional MLH1 protein. So this is a false negative MLH1 pattern, which is a technical issue, which has also been observed in colon cancers and has to be kept in mind while interpreting the IHC of these tumors. This is an example of a castration-resistant metastatic prostate sample to the liver. This had an increased number of mutations. There were 16 mutations. There were no MMR gene alterations found. The MSI sensor score was indeterminate. And on IHC, MSH2 and MSH6 were retained. PMS2 was lost, while the MLH1 showed focal weak positivity. Note the positive, the control, internal control. So this, we think, this was very focal and weak in the tumor. So this was classified as an MSH deficient tumor based on the number of hypermutations and the lack of PMS2 immunohistochemical staining for the protein. And this is also considered to be a limitation of IHC, where you can have focal weak expression of MLH1. So these are important limitations of IHC that have to be kept in mind while interpreting the immunohistochemical status. So just to summarize this portion of my talk, prostate carcinomas with mismatch repair mutation deficiency or MSI high are rare, form less than about 3% of total number of prostate cancers. These are primarily deficient in MSH2 and MSH6. This phenomenon is overrepresented in castration-resistant metastatic prostate cancers as compared to primaries. 22 of the cases which were mismatch repair deficient in our cohort also had a germline mutation in MMR gene. The tumor mutational burden and mutational status of MMR genes derived from NGS is important in the setting of MSI indeterminate tumors. In terms of immunohistochemistry, it's useful in detecting MMR deficiency, particularly in the absence of clear-cut MSI high status, as well as when you have an MSI sensor indeterminate value on sequencing. The second instance with utility is when there's low tumor purity, and which results to an unreliable MSI sensor score, which formed about 25% of our cohort. And lastly, when you don't have tumor available for next generation sequencing, IHC is an inexpensive, it's a clear, validated, and fairly easy to interpret assay, which you have to keep in mind the limitations of IHC while interpreting these assays. And overall, the morphologic patterns of MSI high prostate cancers are not as distinctive as colorectal and endometrial cancers in that they lack or the majority of them lack the tumor infiltrating lymphocytes, et cetera, which are classic for MMR deficient colorectal cancers. So in the next part of the talk, I just want to segue to molecular repair pathways and DNA damage repair mutations, and our work on the clinical pathologic features of tumors with these mutations. So this is an overview of the stressors that cause these DNA repair pathway abnormalities, leading to single or double-stranded breaks, which then lead to either the double-stranded breaks are the most fatal, and there's two pathways essentially for double-stranded break repair, one of which is a homologous recombination pathway, and the genes involved in this pathway are the BRCA2 and 1 and ATM and CHEK, which are the dominant genes involved in the repair of this pathway. This is an error-free pathway because it uses a sister chromatid as a template, and thereby it minimizes errors of replication, whereas the non-homologous end-joining pathway is more of an error-prone pathway, and the genes involved in the repair of these pathways and other genes involved include SPOP. So here's the pie chart from the New England Journal Pathway a paper that I showed you earlier, which essentially looked at 20 DNA damage repair pathway mutations in metastatic or advanced prostate cancers. And as you can see from the pie chart, over 75% of the mutations happen in BRCA1 and 2, ATM and CHEK2. MSH6, there are 2 cases of MSH2 and 6 and 2 cases with PMS2 mutations, which together form about 4% of the total number of these mutations. So MMR pathway mutations are a very, very small subset, whereas the majority are BRCA1 and 2, ATM and CHEK. And this is basically from CBio portal, which looks at all comers, both primary and metastatic, somatic and germline mutations in DNA, all alterations in DNA dependent genes in prostate cancer from our data set. And these are the prevalence of those mutations. Again, BRCA2, ATM, CHEK2, and BRCA1 are overrepresented. And this is commensurate with other reports as well. Here's the breakdown of the germline mutations, which we looked into the clinical pathologic features of this subset. There were 99 cases with clinically significant germline mutations. We started off with these so as to focus on those tumors where we did not have a chance for therapy-induced somatic mutations, et cetera, and we'll be going on to the somatic mutations next. The genes that we looked at included BRCA1 and 2, ATM, CHEK2, PALB2, NBN, and BRIP1. Of these 93 cases, 60 were primaries and 33 were metastatic prostate cancers. We had 41 radical prostatectomies and 19 prostate needle biopsies. And again, BRCA2 mutations were overrepresented and formed 40% of this subset. 12 of these cases had a matched either primary and a MET or more than one MET available to evaluate. Here's a table showing the clinical and pathologic features of these tumors, where we had the primary tumor available, which was 81. The majority were in grade groups 4 and 5. 2/3 of these patients fell into grade groups 4 and 5. 85% of tumors were high pathologic stage. We did look into the presence or absence of lymphovascular invasion in these tumors, and we did not find a significant difference between the two groups. But as you can see here, the intraductal or the ductal phenotype and cribriform architecture were overrepresented in these tumors, forming 49%, almost 50%, and 34% of this cohort respectively. So I just wanted to briefly show you the next couple of slides on the genomic alterations as well as the clinical pathologic risk factors associated with these two histologic subtypes that Dr. Fine alluded to in his talk. This was a multi-institutional effort with over 900 cases represented, where MSK contributed more than a quarter of the cases. Over 165 patients had either intraductal carcinoma or cribriform cancer represented. Of the MSK cases, 71 had biochemical recurrence events and 22 had metastatic disease. So when you stratify cases by intraductal carcinoma or cribriform architecture, the presence of these two histologic features is significantly associated with NCNN intermediate to high risk category, high clinical stage greater than 3, and high Gleason grade, as is shown here by these Kaplan-Meier curves. The BCR rate is 3 to 4 times higher in these tumors, and the metastatic rate is about 4 times higher in these tumors with these histologic subtypes as well. These tumors have also been shown by us and others to have multiple genetic alterations, including SPOP mutations, DNA damage repair gene mutations, as I showed you, SHLAP dysregulations, catastrophic and complex chromosomal events, including chromothripsis, which are basically single-time large chromosomal events, as well as increased percent of the genome altered that, again, Dr. Fine mentioned in his talk. So I just wanted to end with this study from the Johns Hopkins group, once again, looking at primary prostate cancers, where they found that somatic pathogenic DNA repair mutations in primary prostate cancers were significantly correlated with high grade group as well as stage. And 21%, or 1 in 5, of prostate cancers with either a grade group or pathologic stage greater than 3 had any DNA repair mutation, and 1 in 9 had specifically ATM BRCA1 or BRCA2 mutation. So the potential clinical utility of these histologic subtypes to select patients for eligibility for, specifically for PARP inhibitor therapy, has to be kept in mind. To end, to summarize, prostate cancers with MSI high or mismatch repair deficient prostate cancers are rare, and these are primarily deficient in MSH2 or MSH6. They're overrepresented in the castration-resistant metastatic setting. 1/5 of the MSI high cohort had a germline mutation in our study. Immunohistochemistry was particularly useful in detecting MMR deficiency, and particularly in these scenarios. 1, absence of clear-cut MSI high status or an MSI indeterminate status on sequencing. The second, if there's a low tumor purity, which leads to an unreliable MSI sensor score, which formed about 25% of our samples. And thirdly, when tumor is insufficient in amount for sequencing. MMR is particularly useful because it's a clear, validated, inexpensive, and rapid assay. But the limitations of IHC have to be kept in mind, as I illustrated in the few examples. BRCA2 is the most common DNA repair damage gene for prostate cancer, and identifying complex histologies, including intraductal and cribriform histologies, is useful in selecting patients for therapeutic eligibility for PARP inhibitor trials. So I wanted to acknowledge several people, including the GU pathology, my GU pathology colleagues, Jinru Shah, who's our MMR guru, and who helped me a lot with the interpretation of some of these assays, Jackie Heckman from pathology, medical oncology, Wasim Abida, who is the first author of the paper detailing our MSI findings, Howard Scher, and other key collaborators from computational biology and CMO who collaborated on the MSI study. Thank you very much, and happy to take any questions.
Hi, would you advocate doing
Yes, given that, as I've shown, that given that, there is therapy predicated on the presence of MSI high, and the fact that next generation sequencing may not be available in all centers, there are caveats. You might have, there might be cases which fail sequencing, and I've shown that MSI, at least in our hands, is a sensitive and specific study with a good correlation with sequencing results. So yes, in those scenarios, I think reflex performance of IHC might be justified.
Upfront IHC, like we do with all colon cancers get MSI testing now.
Right.
Would you advocate such a thing for prostate cancer?
So my take on that would be that because it's such a small percentage of prostate cancers that are MSI high, it may not be justified to do it in the entire cohort.
Colon cancer is only 15%.
Right, but this is far fewer. So it may be that you might have to screen patients based on if you have sequencing results available, that might be a good way to screen patients. In the absence of sequencing results, I think it's worth it to perform IHC to perhaps, find mismatch repair status, although it's a very, very small number.
It seems to be a lot easier to screen with immunohistochemistry than it does with next generation sequencing.
Yeah, given that you don't, it's certainly a very reliable and sensitive and specific assay to pick up these, and very cheap, yes.
It's not cheaper, actually.
No.
I think
It
also
depends how much you bill for immunohistochemistry.
When you get to high grade.
right, in a high grade or advanced setting, a metastatic lesion in the liver, for instance, about 1 in 5,
Yeah,
I think you said,
sure.
is the prevalence there in this disease. So maybe the advanced disease more.
Yeah, in the back, I'm sorry, I can't see who it
Can
is.
you comment on the mechanism of MSH2, MSH6 loss? You showed that one case that had mutations in the MSH2, MSH6, but then some of the others that were you able to find a mechanism of loss?
So the other mechanisms of loss are loss of heterozygosity as well as methylation in those genes. And if there was not a mutation that was readily diagnosable, I guess one of those other alternative mechanisms might result in a mismatch repair deficient phenotype.